first, we're just going to look at the pelvic floor. This is a kind of a bird's eye view from above. So we've got the front of the pelvis, and then we've got the back of the pelvis, which this is the tailbone, the end of the spine. And then we've got the rectum, vagina, and urethra. And this is a female pelvis, but the male pelvis actually looks very much the same, except there isn't an opening for the vagina, and the pelvis is a little bit more narrow. And this is just an image to kind of show you there's quite a few muscles inside here, and this isn't even showing all of them, but we've got muscles from front to back, side to side. We've got some hip rotators in there. We've got muscles that wrap around the entrances, like of the urethra, the vagina, the rectum, and the muscles have various functions, which we're going to look at in the next slide. But if you take a look over here from the side, you can kind of see this is the end of the spine here, and we've got the uterus right here. We've got the bladder right there. We've got the rectum there. So we've got a bunch of organs that are kind of bundled in at the base of the spine. And then we've got the pelvic floor at the very bottom. And so we've got 5 main functions that the pelvic floor is responsible for. It's responsible for maintaining continence of the bowel and bladder, so making sure that we can hold our pee and poo, allowing sexual function and pleasure. So it's both like allowing for sexual penetration, but also being able to enjoy that. Providing support to the internal organs. So what that means is being able to hold up the bladder, the uterus, the lower colon. It also provides support to the low back and hips so that we can function without pain. So that's movement control, our hips, our pelvis, our low back. These muscles actually work to control, stabilize, move so that we have pain-free movement. So we'll look more into that, but sometimes pain, like low back pain, hip pain, pelvic pain, can be linked with dysfunction in these muscles. They also help our circulatory system get blood and other fluids from the legs to the heart. So as they contract cyclically, they're a gateway for major blood vessels to pass from the lower limb and up. Also, we're looking at lymph fluids. So if there's excessive swelling in the lower leg, sometimes pelvic floor muscles can actually be playing into that if they're too tight and there isn't a good blood flow exchange. And so for pelvic health, and pelvic floor physiotherapy is becoming the leading therapy of choice in the fight against incontinence and pain. It says in women because this is women's pelvic health, but there's like a lot that it can do for men as well. It's pelvic dysfunction. When we talk about it, generally we're looking at what are the muscles doing inside the pelvis. And there's usually a combination of things happening, but if we categorize into general trends in the pelvic floor muscles, what we see is hypotonic muscles, which are generally weak muscles, and they contribute to stress incontinence. So that's incontinence if you're laughing, sneezing, jumping, but not always. Sometimes overactive muscles can contribute to that. And pelvic organ prolapse. So that's where we've got like the uterus or the bladder or the colon that's dropping down. And that's usually pretty rare unless you've had childbirth or trauma. Then we're looking also at hypertonicity. So this is tightness in the pelvic floor muscles. And I think this is the part that people get surprised by and is usually under-addressed. And it's actually way more common than the weak muscles. Most people think, oh, I can't feel my pelvic muscles, they must be weak. Most people have trouble relaxing their pelvic floor muscles, and tight pelvic floor muscles contribute to urinary and fecal urgency. So that's feeling like you've got this uncontrollable urge to go to the washroom, sometimes where you might not even have to go. Urge incontinence, so that's where you feel like quite a big urge to go to the washroom, and it might be so sudden and extreme that you can't hold it. chronic pelvic pain, dyspareunia, which is painful sex, vaginismus, which is also essentially painful sex, but it's a hypersensitivity of the entrance of the vagina, which is also what vulvodynia is, pudendal neuralgia, and interstitial cystitis. So these are just common conditions that are linked with overactive muscles, but somebody might not have any of these conditions and have a combination of weak and tight muscles in the pelvic floor. So like when we're looking at optimal function, we're looking for muscles that can contract and relax and that aren't causing pain. And so a therapist who's trained in the area would check all the muscles of the pelvic floor to assess what they're doing, and based on whatever concerns are brought to the therapist, try to figure out what the muscles are doing that needs to change in order to get things better. And yeah, when we're looking at hypertonicity and pelvic pain, we're usually looking at tight pelvic muscles. So muscles that are tight, they're contracted, they're having trouble relaxing. So I wanted to go now into a definition for chronic pelvic pain, because this is important in understanding endometriosis and some of the changes that happen. I'm just going to check here. Okay. So chronic pelvic pain is defined as pain below the umbilicus, so that's the belly button, for at least 6 months in duration. And it's one of the most common clinical manifestations of endometriosis. Between 71 and 87% of women with chronic pelvic pain have laparoscopically proven endometriosis, but lesion location correlates poorly with the location that patients identify as their intense areas of pain. And you will understand more about that when I go into some of the causes of pain and why, like, it's not localized to just the uterus, for instance, but like a widespread area of pain. Treatments for endometriosis have focused on hormonal therapy and surgery, both which topic the endometrial lesions. This approach can control the extent of the disease, but it often fails to provide a durable solution for the associated pelvic pain that comes with endometriosis. Central sensitization, which we're about to address in the following slides, and myofascial pain, which we're also going to talk about, secondary to active trigger points in the muscles, likely constitute a source of initiation, amplification, and perpetuation of pain, and either could perpetuate symptoms in women even after surgical and medical hormonal treatment for endometriosis has been optimized. And that's important because the treatment for endometriosis is really important, and whatever doctor you're working with, or if you have a specialist, they would determine what line of treatment happens. And usually they start in one place and see how it goes. And if it's not effective, they follow another. And that controls the actual endometriosis, which is the growth of the lining of the uterus that starts to grow outside the uterus. And usually it stays within the pelvic region, but sometimes it has been shown in certain cases to grow outside of that. But what hormonal therapy or surgery does is it controls the growth. And usually once the growths are controlled, people are still often left behind with pain. And this is really where my talk about pelvic pain and the myofascial structures is going to come to be important for knowledge, because it will give you the opportunity to actually create some change. I also recommend, like, this isn't as common in the medical community, but there's a book, for instance, called Woman Code, and there's also other information out there, but it teaches you how your hormones cycle and finding the best balance in your hormones, and often like modifying little things in our lives, like reducing sugar intake or reducing stress levels, can really help to balance the hormone levels out, which will help with the endometriosis as well. So I recommend that absolutely. But this talk going forward is going to give you a perspective on like the changes that happen from the endometriosis and which might last after treatments taken place. And so how we can affect change and live better in our bodies and feel like we're in less pain. Okay, sorry. Okay, so chronic pelvic pain. So when we look at pain, the definition for it is an unpleasant subjective experience arising from the central nervous system that normally alerts and protects the body from potentially nauseous stimuli. And so like pain is helpful, even though we might not like it, but it's telling us there's something wrong. But this is acute pain. When we go into long-standing pain, which persists well after the inciting stimulus or injury has resolved. So let's say endometriosis has been treated and you're still having a lot of pelvic pain or hip pain or abdominal pain, and you're wondering why. Chronic pain persists after the stimulus has been removed, and it's the result of functional and structural rearrangements of the central nervous system that both sustain the perception of pain and facilitate its expansion to distant regions. And I have this image here. Is it being blocked at all for you guys, the image? No? Okay, good. So I'm just going to move this for myself. So we've got, this is just to show you that there's a lot of brain regions involved with processing pain. So these bottom images are functional MRIs, which mean like somebody goes into a machine and the areas of the brain that are active will light up. And so there's many regions that process pain. And when somebody's experiencing chronic pain, these areas tend to expand, so they become overactive. And the different regions can be related to sensation, movement, memory, emotion. And that's why sometimes when we're feeling painful, you might have like a strong emotional response with it as well. There's a lot of different areas, and for each person, it's quite unique what areas of the brain actually light up and get active. So I keep on moving this thing to the wrong place. Sorry, 1 second. Okay, let's try that. Okay, so we're going to look at the neural mechanisms in endometriosis associated chronic pelvic pain. So like what in the neural system propagates this pain. And so how do ectopic lesions, these lesions from endometriosis, how do they activate the nervous system? So first of all, I included these images on the side just because they kind of demonstrate what I'm talking about. But first we've got the lesions, which in order to grow and survive actually need blood vessels and blood supply. So the blood vessels start growing, and therefore there's all these factors released in the blood supply that's helping the blood vessels to grow. But then also with the blood vessels come nerve supply. And so you've got increased growth factors for nerves. So you've got a lot of neural sprouting, both of the sensory and autonomic, specifically the sympathetic nervous system nerves, and which are sprouting to innervate the lesion. Then sensory nerve fibers, they respond to nauseous stimuli and transmit pain signals to the central nervous system. So that's the spinal cord and brain, and are especially sensitive to immune and inflammatory factors, which are prevalent in endometriosis. So every time the menstruation occurs and there's we shed the lining of our uterus, in endometriosis, you're having extra uterine, so outside of the uterus, menstruation, which causes inflammation. So this additional inflammation, and then you've got increased nerves that have sprouted, starts creating an increased increased signaling of pain, which we call nociception, pain to the nervous system. And then repeated or prolonged activation of the sensory nerve fibers from like every time, for instance, it might at first just be when you menstruate, but then it might be at other times of the month. This prolonged activation lowers the activation threshold in the nerve, which means that the nerve fires with less stimulus. And this is called peripheral sensitization because it's happening in the periphery, it's happening at the uterus. And this process leads to the release of substances which actually cause neurogenic inflammation and increase the nociceptor, which is pain receptor expression. So to kind of give a brief overview of all of that, we've got increased nerves coming in to supply the endometrial tissue. With that, we've got an increased stimulation of them because there's increased inflammation in endometriosis. So these increased nerve fibers have increased firing. And the more that cycle happens, the threshold for pain starts reducing, and then we get more receptors, which means the signal for pain is so easily sent to the nervous system. And initially, these visceral nociceptors, pain receptors, which are mostly silent, even with intense stimulation in a healthy person, and in a person before they have significant signs of endometriosis, they may become activated once sufficiently sensitized by the inflammation. So they were silent before, meaning they weren't signaling any pain signals, and now they've been sensitized, and so now they're signaling much more easily. Just 1 second. Just making sure that I'm not missing anything here. 8, 9. Okay, we're good. And so when we've got ongoing pain receptor activation, this generates a bombardment of nauseous information into the sensory branch of the spinal cord. And this leads to functional and structural changes at the spinal cord and ultimately central sensitization. And central, when we talk about central, that's the spinal cord and brain. And this leads to exaggerated responses to peripheral stimuli. That means something that might be thought of in the past as like a minor a stimulation that didn't cause pain is now being interpreted as pain. And there's different manifestations clinically of central sensitization. We've got allodynia, which is pain to a non-nauseous stimuli, which is like basically maybe if I kind of took a Q-tip lightly and kind of pressed it into your skin, you might think like, oh, that doesn't hurt at all. But once you've had central sensitization, the brain actually interprets that as pain. And then hyperalgesia is an increased pain response to a painful stimulus. And then referred pain is pain that's perceived outside the area of the nauseous stimulus. So like, let's say in this example, like of this picture here, if there's a stimulation coming in at the foot, when you've got referred pain, you might feel that outside, like this guy is stepping on fire, so the signal should be in his foot or his toes. But if you've got referred pain, you might feel that outside that area. And as we go further into that, you'll understand what referred pain means, because I'm going to explain exactly where it gets referred to for people who have endometriosis. So it can amplify and perpetuate the perception of pain long after the initiating pathology resolves. So once this cycle of events happens, and let's say it's been happening for like a year or two or maybe more, and then you have treatment, which is really helpful, you might still have some of these pain changes that get left behind. And we'll talk about like the techniques that we can do to kind of start to rewire that pain perception and have some plasticity. And so why is central sensitization important with CPP, with chronic pelvic pain and endometriosis? And there's two main reasons. One's called viscerosomatic convergence. And that sounds kind of complicated, but viscera is like the internal organ. So we're looking at the uterus. So somatic is like the skin and the muscles. And so basically the spinal neurons that receive information from the viscera, so every single level of the spine receives information from both internal organs, viscera, and muscles. So the spinal neurons that receive input from the viscera also receive sensory information, sensation information from the muscles and skin. Therefore, like it hinders the precise location and discrimination of sensory information. And this is the basis for referred pain and why visceral pain is often felt in somatic structures, particularly muscles. So you might hear that somebody has a heart attack and they feel pain down their left shoulder and arm. And it's because the heart is innervated at a specific level of the spine that also muscles feeding into the neck and shoulder also summate at. And so when you look at the uterus here and the entrance of the vagina, there's two major regions that the sensory nerves go to. It's between mostly sacral level 2 to 4, but pretty much the lowest level of the lumbar spine to the base of the sacrum. And then this area in the lower thoracic spine, like around where the diaphragm connects to. And these areas, like the muscles that are influenced by these two areas, this area right here in the thoracic spine, this is kind of like the back muscles, the abdominal muscles. And then down here, this is the pelvic muscles. This is the hips, low back, back of the leg. So what this means is when information of inflammation and pain is coming into the spine at this level, the brain loses ability to decipher, is that coming from my uterus or is it coming from my muscles? And that kind of crosstalk over time creates a cycle where the pain is perceived in a widespread area. And then we'll look in a second also at how the muscles get affected by that. So there's also something called the viscerosomatic reflex. So again, it's the viscera, like the uterus, and then somatic muscles. And ongoing visceral input can lead to increased muscle tone and spasm. So in any of those areas, and it's usually in the area of pain referral that happens. So in this area, it's the low back and abdomen. In this area, it's the pelvic floor, hips. So increased this input, pain input from the endometrial tissue from the uterus can start to create muscle pain and spasm in the muscles that are referred at the same level. Additionally, guarding reflexes, which involve heightened sacral reflexes from this area, are triggered by visceral pain and inflammation, can also contribute to the muscle tightening and results in pelvic floor dysfunction. And this kind of just an image of how it's all kind of connected and feeds back into each other. So you've got that loop of visceral organ pain that causes hypertonic tight muscles, but also then the sensory input from these muscles will affect pain perception in the organ. And then when we've got that sensitization happening at the spinal cord and brain level, it starts to impact how we perceive pain in both those areas. So now we're going to look at the contribution of the active trigger points. So sorry, what is this? Okay, to chronic pelvic pain. And so myofascial pain arises from dysfunction in the muscles and surrounding connective tissue and is diagnosed by the presence of myofascial trigger points in the area that's symptomatic, so in the area that hurts. Myofascial trigger points are small, palpable, hyper-irritable nodules located on top bands of skeletal muscle and are in a sustained state of contracture. So I just used this image because it kind of shows really nicely like what the muscle fibers kind of look like when they're in spasm. But basically in a muscle, you've got a bunch of parallel lines of bands of muscles. And in each of those bands of muscles, you've got units that are lined up of these almost like comb-like structures that are in a relaxed state, kind of like this. And then as the muscle contracts, they go together to shorten the muscle, and then the muscle relaxes and it does that. And so when we've got these little bands of hyper irritable skeletal muscle like knots and trigger points, the muscle goes into a state of contraction, and then it's in that state. It doesn't mean the whole muscle's in that state. It's usually like certain fibers and certain bands of muscle, and it can create pain in the muscle. It can also create movement dysfunction and other sorts of things. And you've probably known that if you've ever done self-massage or had like knots worked out at the massage therapist, they're usually working on trigger points. The thing is, we also get trigger points in the muscles inside our pelvic floor. And this is just adding to that a little bit, that the contribution of active trigger points adds to chronic pelvic pain. They can be spontaneously painful, which means like if you're having an active area of pain, that means they're active, but you might like go to the massage therapist and think you're feeling really great, and then you lie down and suddenly you're like, whoa, that was way more painful than I ever thought. And that's because that's a latent trigger point. So a latent trigger point will only be painful when you press it. Active ones cause pain actively, and they're believed to occur secondary to muscle overload or overuse. But the more research that's being done, we also know that inflammation and visceral dysfunction from the viscerosomatic reflexes and convergence can also lead to trigger points in the muscles. They also myofascial trigger points may also cause motor movement autonomic disturbances and may affect the function of the visceral organs. They're commonly found in chronic pain conditions, and when active, typically present as regional pain syndromes. And I just used this picture because you can see here that like the muscle itself is in the picture to the side, and that has some trigger points along the muscle fibers. But as you see here, it is painful along the muscle fibers, but it also refers pain to these other areas of red. So this is referred pain. This is a pattern of referral for this muscle. All right. So myofascial trigger points can be found throughout the body, including the pelvic floor, where they refer pain to the vagina, urethra, rectum, coccyx, sacrum, lower back, lower abdominal area, and posterior thighs. And so this picture at the side, you kind of see like the various muscles and where they can lead to pain, like around the urethra, around the rectum, inside the pelvis. It can also be the lower abdomen, inner thighs, outer hips, low back, a perineal area. They may also refer pain from these muscles back to the pelvic region, making myofascial pain difficult to localize. Because of that convergence, you might start to feel that the muscle pain is actually in your uterus, and you think that, oh, it feels like it's endo pain, it feels like I'm getting a period cramp and it feels terrible, but that's being treated. But because of the convergence, my brain interprets those trigger points that are sending the signal as pain in the uterus as well. So just give me 1 second. Okay, 16. I'm just checking. Okay. So dyspareunia, this is painful sex. Dyschezia, which is painful defecation. Dysuria, painful urination, are the most common symptoms among women with myofascial pelvic pain, though these symptoms can also reflect coincident gynecological, gastrointestinal, and urological conditions. So we're talking today about endometriosis, but there's lots of different conditions that can be related to the pelvic floor. Within the pelvic floor, previous gynecological surgeries, childbirth, injury, injury meaning like maybe falling while snowboarding or having a fall on your tailbone or having a motor vehicle accident, sexual abuse, having pain with sex, improper mechanics, maybe you broke your ankle and didn't have it properly treated and then you were walking in a weird way for a while, may all contribute to myofascial trigger point formation. They may also develop secondary to visceral disease, which we were talking about, and specifically in this case, endometriosis. So just like you could have everything else that's perfect, like not have any of those, like any accidents, no sexual abuse, and no childbirth traumas. And if you have a visceral disease, for instance, endometriosis, but there are other ones as well, like painful bladder syndrome, different types of gynecological or gastrointestinal issues like IBS, for instance, or Crohn's or colitis, they can all create trigger points in these muscles. And this is just a view of other muscles that are in the surrounding area that are also innervated by the uterus. And so also like basically all around the hips and low back, abdominal, like any of those muscles can be affected. These just kind of show you where pain is perceived in certain muscles. And actually this one right here with the pain at the tailbone, this is kind of interesting because pain is perceived right here and in the back of the thigh, but the muscle is actually out here. It's a muscle called obturator internus. It's a hip rotator. It's a huge muscle that's connects to the hip, but the whole body of the muscles inside the pelvis, and it can refer pain to the tailbone. And so sometimes I have patients who have tailbone pain and there's nothing indicating that their tailbone should be sore, but the obturator internus is in spasm and it's causing them tailbone pain. So the myofascial component to pelvic pain adds another dimension to endometriosis and requires its own diagnosis and treatment. It's usually performed by a pelvic health physiotherapist. That said, there are now like naturopaths who are taking the courses, and they're good for dealing like really specifically with the pelvic floor. But from my experience, I think like the ability to assess the muscles usually comes better to physiotherapists because that's their whole line of training, not just being a doctor. So once formed, myofascial trigger points can become self-sustaining source for pain even after the visceral insult has resolved. So for endometriosis, myofascial trigger points that develop secondary to disease could sustain the pain and dysfunction despite lesion removal and hormone management. I know I've said that like now probably 5 or 6 times, but it's important because people come in to see me a lot and they're confused as to why like they're still in pain, and sometimes they want to go back to the specialist because they're worried that there's still some tissue left behind or something wasn't managed properly when it was. It's just that there's these other elements that need to be addressed. And usually people do pretty well with treatment once they understand like the cycle of everything that's happening. So active myofascial trigger points serve as a source of ongoing nociception, so pain, and they reduce pain thresholds, enhance visceral and referred pain, and sensitize the nervous system. So they play into that whole cycle of chronic pain also. Yeah, I just put that image there. Okay, so there are different techniques for releasing pelvic pain. This was really there was only 1 or 2 images that I could actually find that kind of demonstrate what's going on. But it's basically internally, either vaginally or rectally, depending on what the symptoms are. And if there are any like tailbone or rectal symptoms, it's recommended to have both a vaginal and a rectal assessment. But myofascial, the muscles inside the pelvis would be treated through an internal assessment, but there's also muscles outside the pelvis and the lower back that need to be assessed and addressed. So myofascial release is a set of treatments which involve physical therapy and other manual techniques, including deep pressure massage, internal and external, stretching techniques, joint mobilization, fascial release, for instance, with foam rollers, or like going to a fascial therapist, often in combination with teaching strategies used to manage pain, including breathing techniques, relaxation exercises, and mindfulness. And this is really important because this dual approach addresses both the physiological and psychological components of chronic myofascial pain. It alleviates the myofascial trigger points related to pain, offers coping strategies during painful episodes, and facilitates plasticity. This is neural changes, neural plasticity in cases of central and peripheral sensitization after surgical and hormonal treatment have been undertaken. So if the nervous system can shift in one way, it can also shift back. It's really adaptable. What you put into the system is what changes it. So the more we can use breathing, relaxation, mindfulness, muscle releasing techniques to reduce the pain and calm the system, we can start to change the shape of change the way the input is being interpreted in the brain, and start to kind of dim the lights on those lit regions in the brain which we're lighting up for pain. They can start to get smaller and reduced, and therefore we can reverse central pain as well, and central sensitization. The other techniques are injections with or without topical anesthetic. So that's either wet or dry needling. Usually like the theoretical basis of trigger point injection is that entry into a hypercontracted muscle causes a mechanical disruption that interrupts the sensory signals that cause its formation. And so like I use acupuncture because it's helpful to promote blood flow, and also to help balance the nervous system. And I do dry needling, which is a different technique on those top bands of muscles, but all of that's directed outside the pelvis. From my knowledge, there's none done inside the pelvic floor. I do think some maybe chiropractors or certain doctors do try to approach the inner muscles from the outside. It is being studied right now. When we look at acupuncture, the needles are extremely tiny, and it's not like an injection, it's just creating a stimulus. If we're looking at a wet injection, which is using anesthetic, usually lidocaine is the most common used, and it can be helpful like in combination with these other muscle releasing techniques. If people aren't undergoing a lot of pain, it can be kind of tricky to break the cycle sometimes. And when it's tricky, using medication to stop that cycle can be quite helpful. And having an injection in a trigger point or site or a region of pain can help to lessen the pain of that area so that we can start to create a shift and be able to tolerate treatment. The third thing is Botox. And this is also like being researched quite a bit right now, and so it's a lot less commonly used. And usually both wet injections and Botox are considered like once conservative treatment, meaning like physiotherapy, muscle techniques like mindfulness and breathing. Once they've failed to provide adequate relief, Botox is considered. And it suggests that it may be effective in treating endometriosis. That's what the research suggests, by alleviating the hypertonicity when the dose is carefully titrated, so matched in quantity in the correct amounts to the person and to the muscle. Excessive muscle contraction and spasm can be eased without the muscle paralysis. It usually lasts 3 to 6 months because Botox paralyzes the muscles. So you can get a dose if the person who's doing it is well trained and everything goes well. You can get a dose that diminishes the muscle spasm, but still allows the muscle to function without it being like paralyzed. And that lasts 3 to 6 months, and then it needs to be done again. So that is the end of the presentation component. And I think now we're going to have some questions coming in.
Yeah, thank you, Natalie. Wow, that was so much information. I'm very, very like full in my brain, and it's just so great. So Laurel, I don't know if you want to pop on and potentially ask your questions now, but it would be awesome to walk through some questions that you have about someone who, experiences endometriosis firsthand. What your questions for Natalie in relation to pelvic health are specifically.
Okay, so I have some questions. They're not specific to me necessarily. I actually have a few friends who have endometriosis as well, and I got their opinion. So these are some questions that came up. So one of the questions that someone was interested in is why women have more pelvic health issues than men, and if that's actually accurate.
Like the research done with the National Institute of Health in the States, which kind of would like cold call people and ask them. And it's like the best gauge that we have of that actually shows that one in 5 men and 1 in 4 women suffer from pelvic conditions. Like if we ask them questions that would indicate dysfunction, they might say, oh, I'm fine. But if we ask them certain questions and they have certain symptoms, it indicates there's dysfunction. So there's a high proportion of men and women. I think with childbirth being a factor and pregnancy, like women and like now people talking about pelvic health, women tend to seek help much more often than men. And also like with periods and a hormone cycle and certain conditions that affect women maybe more than men, you'll see pelvic floor issues being more common in women in that sense. But I think women and men are almost equally affected by problems with the pelvic floor. It's just that usually men are, I do treat men. It's just they usually only come to me when they're desperate. Yeah. And it could be like pain in the prostate. It could be low back or hip pain that's gone unresolved for a long time, and then they have a history of falling on their tailbone, and then they're having also trouble like emptying their bladder, pain, or like there's different presentations for everyone. But it could, like I talked about the 5 functions of the pelvic floor, basically in any of those domains and any mix of things can happen to show dysfunction in the area. So some people might be like, well, I can hold my bladder completely perfectly. I have no pain with sex. So I don't have pelvic problems, but they have back issues. And that doesn't mean that they don't have pelvic dysfunction. It just might be just showing up as back pain for them.
Perfect. Thank you. That makes so much sense that not as many men are coming forward about it. That makes a lot of sense.
They may with time, you never know.
Yeah. Okay, so a couple more, let's see. Is there any exercises that you can do on your own? And is there any repetitive movements that should be avoided?
Yeah. I say the best exercise to do on your own is relaxation, actually. Because the thing is that like a lot of people want to do Kegels and strengthen the pelvic muscles, but there's so many muscles, as you saw, like I'll go back there actually, so we can kind of look at that. There are so many muscles inside the pelvic floor. Here, like, and this isn't even all of them, but there's so many that like when I'm checking muscles in somebody who comes to the clinic, I'll palpate them. And usually if the muscles are tight or in spasm, I don't always check the strength of them because I want the muscles to relax before I know that. But if I was to give, for instance, like a Kegel exercise, these muscles might already be in a state of contraction. And by giving them a Kegel, they're tightening already tight muscles. And that's why some people actually feel like an aversion to wanting to do Kegels or core things because they're like, oh, I don't like it. It makes me feel nauseated, or I just don't like the feeling. Sometimes it's a sign that there's overactive muscles. usually like one of the cues that I give to people if I haven't checked their pelvic floor and I'm trying to get them to tap into it is like if we're talking about contraction, I get them to visualize for women a ping pong ball at the entrance of the vagina, or like a tampon or something you would put inside but almost falling out right at the opening. And imagine that you're wrapping very gently around it and then relaxing it and feeling like, how easy does it feel to wrap? How easy does it feel to let go? Some people might feel like, oh, it feels really like quite easy to wrap, but then I don't feel anything release. And that's usually a sign of overactivity. Usually I use that as an example because the entrance of the vagina, the sphincter muscle, like tends to be the weakest link. If there's any, like it's usually more these back muscles that tend to be tighter, but it really depends on the person and the condition. But something that's universally helpful for everyone, no matter like if you've got like overactive muscles or not, it's relaxation and do you know child's pose? Happy baby, any kind of hip opener poses, or lying on your back with your legs up the wall, or if flexibility doesn't permit, you're lying with your legs bent at a 90-degree angle. Maybe they're on the bed or on the couch while your back is on the floor. And I say 90-degree angle and greater, so like child's pose supported with cushions or whatever, because when the hip is flexed to 90 degrees or more, it actually helps the pelvic muscles to relax. And that's kind of the idea behind also the squatty potty. If anybody's heard of that, it's just like a stool that wraps around the toilet and you can put your feet on it and it elevates your knees above your hips so that your pelvic muscles can relax and it's easier to have a bowel movement or to pee. But breathing diaphragmatically. So if you were to put a hand on your chest and a hand on your stomach, and ensuring there's no movement in your chest and your belly is moving as you breathe in, it's expanding, and as you breathe out, it's releasing. When you breathe in and your belly fills with air, your diaphragm's dropping, and your diaphragm works like in partnership with your pelvic muscles. And so as that belly expands, it's almost like a three-dimensional kind of balloon, at least on the bottom. And so as your belly fills and the air is dropping down into the lungs and the diaphragm's contracting, your pelvic floor is relaxing. So it's lengthening and dropping down. And so if you're in a hip opening position and you're breathing in a very relaxed way into your belly and you're really relaxed, you can feel your pelvic muscles very subtly, but dropping down. It almost feels like you're breathing into the space around your tailbone, between your sit bones, into the rectum. The group of muscles here is called levator ani, which in Latin means lift the anus. And they have a lot of different functions, but when you think about it, it's most prominently felt in the anus. And so when you feel them relax, you'll feel the anus dropping down. And so that's the best exercise that I can share, like without having pelvic floor being assessed, and especially like if we are talking about a population with endometriosis, both because that helps to move your body into the parasympathetic mode, like rest and digest, and calms the nervous system, breathing diaphragmatically, but also mechanically lengthens and relaxes those muscles. That's like the best exercise I can recommend without having assessed anybody.
Thank you. That's great. And another question. This is actually just like coming to me now. So it's like off the top of my head, but I learned about pelvic floor muscles through a yoga teacher training through post and prenatal yoga training. I had never heard about it otherwise, and I've been diagnosed and living with endometriosis for a while. Why is it that doctors don't talk about pelvic floor health, especially with endometriosis patients? And why don't they talk about it also with women after they've given birth? Because a lot of women have issues with their pelvic floor after they've given birth. And it's never really something I hear people talk about or doctors talk about.
Mm-hmm. I think it's actually lack of knowledge and understanding. It's really been mostly, I mean, it's been around since the 80s, pelvic floor therapy, but it's really in the last 10 to 15 years, a huge body of research in all these different areas is coming out. And if doctors aren't educated or staying on top of the research, the common work, and especially like a general practitioner, if you're not talking about an OBGYN, but actually I know that like OBGYNs and even nurses like on the maternity ward won't necessarily refer to pelvic health. Even midwives, it's surprising. I see a mix, like I'm seeing more and more and more doctors and midwives and nurses referring, but I think it's knowledge and information, and the more that they have it, the better. I used to work at a sports medicine clinic where the one of the founders, he founded the clinic with an osteopath who's has a background in yoga, and he was like, why are these people not getting better, these low back and hip pain people? And she was like, well, they all have pelvic issues. And he's like, well, we need to start a pelvic program. And that's actually how I got into pelvic therapy, because I was working there and they thought that I would be a good fit for becoming a pelvic therapist as well. And so the more he learned about it, he started conducting research and gathering information. And because he's a physiatrist, a sports medicine doctor, he started conducting talks and educational experiences for other sports medicine doctors to educate them about pelvic issues. And I know, like, just because of that, at least within Toronto, but also like he has an influence outside of that, those doctors were more aware of it. So I think depending on the conferences doctors go to, what they're reading, like how on top of research they are, their own experiences with it in their own lives, that will determine why they're talking about it. I think when they know about the issues and like how much research is behind it, they do refer because they believe it. It's just it takes a facilitator. Like, and I think being a facilitator is like, if you've had an experience, like go back to your doctor and say, hey, like I was having this pain for all this time, and then I went to that therapist and like these issues resolved and pretty quickly, and it was really helpful, so that they know like, oh, like this is good, it works, and this is what it can do.
That's great. Thanks. I think we have time for one more question. One of the questions was, is there any myths that you want to debunk about pelvic floor health? I know you mentioned that a lot of the times people don't realize that actually having like an overactive one is not well known, but is there anything else that you've heard that you would like to debunk?
That's the first one that comes to mind because it's such a huge one. Because the funny thing is, even after I assess people and I'm like, okay, all your muscles need to relax a bit more, you are not weak at all. You need, like, the muscles are weaker because they're held in a state of contraction. You need to learn to relax your muscles. Even after I say that, people still sometimes don't get it, and they're like, I'm weak, I want to strengthen, because it's so ingrained. So I'm going to say, like, keep it as that's the myth I want to debunk, because it's so important. Because like there's so many muscles in there, and because these muscles are innervated by both the autonomic nervous system and the somatic nervous system, meaning like we can move and control them like any other part of our body, but also they're controlled under the level of our awareness, because, and they have tons of reflexes because they're involved with unconscious functions like bowel and bladder and sexual control. They like the nervous system, so like stress, anxiety, all that stuff actually feeds into that cycle and makes them more active. Also, like sitting a lot, especially if like you're slouching and weaker in the core, like that can all add to overactive muscles. And so like really being aware that a lot more commonly people have muscle tension issues rather than weakness, like that's the biggest myth that I want to debunk. Because being weak and hearing exercise videos, do a Kegel, contract your pelvic floor, like usually it's actually your deep abdominal muscles that need to do a better job of contracting, and the better they work, your pelvic floor can actually relax more because they work together. So Um, I can't really think of another one though. Oh, another one should be that like I was looking a little bit at the expressions of people's faces that I could see, at least when there was the image of the internal release, and it was kind of like, oh, like, and I think like when you think about like, oh, I've been for a pap smear before and that's not very pleasant, and now like I've got this person who I don't know very well who's putting their hands in my vagina or rectum and releasing these really sensitive muscles, it can be quite like scary. It doesn't have to be painful. If the person's gentle enough and intuitive enough and paying attention, you can release the muscles in a way where it might like feel like pressure and not be like the most pleasant thing, but you should be able to fully relax and it shouldn't have to be painful. So and that's a myth, like with any type of massage and muscle releasing work. Like if you are tensing your body, it's not a good sign. You have to be able to be relaxed to tolerate the treatment. But pelvic treatment shouldn't be painful.
Thank you so much. That was great. There's one question in the chat if you have time to answer it.
Yeah, of course.
Andrea asks, why can endo pain or pelvic pain continue after menopause?
Yeah, well, that is very, it's kind of the same reason why it can continue after having treatment for endometriosis. Like once the after menopause, the hormones are significantly reduced, so you're not shedding the lining of your uterus anymore. So you've got less pain and inflammation and bombardment. But if you've already gone through that for a significant amount of time and you've got that lowered threshold for pain, you've got peripheral sensitization and central sensitization, and then maybe also like playing into that, the muscles inside the pelvis are like also tight and making you feel as if it's in the uterus or endo pain, but it's actually not. It's that cycle left behind from being in pain for that period of time that needs to be addressed. It's the same as like if somebody has surgery or an intervention that works and treats the endometriosis, they need to address that cycle that's left behind, which again, the best way to treat that is through going to a practitioner who you trust, maybe pelvic health. I think that would be good, but I'm also biased, and rightly so, because I see how helpful it is. But also like having the outer muscles around the hips, abdomen, lower back addressed, making sure that the muscles are working functionally, strong, supportive, but also there aren't trigger points in them. And then also working on the nervous system and breathing and making sure that you're not under like a constant state of stress. So that will help you to move out of that central and peripheral sensitization model, which perpetuates the pain after either treatment or after menopause. So when the endo is no longer active and we've got that kind of pattern left behind.
Thanks,
Awesome.
Laurel and
Thank you so much,
Natalie.
Natalie.
Yeah. Now, Laurel, is there anything else that you want to add? Or, I mean, I know we're definitely over time, so thank you so much, everyone who's still here. This has been so much more additional knowledge that we've been able to take away from these questions. But Laurel, I just want to make sure that there's nothing else you want to add before we move on.
Nope, all good on my end. Thank you so much, Natalie, for answering those questions.
Welcome.
So, I mean, at this point, I think, we've been on this journey for the last hour and a half, which has been so amazing. There's so much knowledge and takeaway for those who are still here. If you do have any questions, feel free to pop them in the chat, and we can quickly address them if you'd like, or we can also, continue the conversation outside of this space. Natalie is available for further connection, and also you can reach out to me personally. My name is Brooke, again, through Creating Connection. We're happy to answer any further questions outside of this conversation. And we also recorded this event, so it will be living on the Creating Connection blog, so you can revisit it again, because we've got such great resources here in regards to photos and also a great description that Natalie went through, that you can rewatch this video and take in knowledge again at your own pace, because like I said, there was so much to learn. So In saying that again, Natalie, thank you so much for spending the time with us today. This was such an amazing presentation, helping us explore how pelvic health and endometriosis can go together. And yeah, I just feel like this is a really great opportunity for everyone to learn. So, unless
Great.
there's anything else, yeah, go ahead.
I just wanted to say that if anyone has personal questions that they do want to direct towards me and they didn't want to bring it up in the chat, they can always email me. And I think my email's like somewhere.
I think it should be at the very last slide in the presentation. But I have everyone's email from the registration for the Eventbrite link. So I can always send all of this information in a recap email for you all, so that you have it in your inbox when it's a good time for you to connect. So thanks, Natalie, for sharing that insight.
This was the biggest event I've been to in over a year.
Yeah, it's kind of the new way of doing things now, isn't it? Well, thank you. We're very grateful for
Thanks
this
for
experience,
hosting.
and look forward to maybe doing more opportunities with Creating Connection, and you in the future. And
Yeah.
for those of you who are new to Creating Connection, again, thank you for spending time with us on your wellness journey today. If you're looking for further events to support yourself in whatever feels best, whether that's movement, meditation, further knowledge sharing opportunities like this today, you can check out our events on our website at creatingconnection.co, and enjoy the rest of your evening. Thank you so much, everyone.